Dr. Pratap Reddy, Dr. Srinath Reddy, Lord Nigel Crisp, Mr. Varma, ladies and gentlemen, it's a pleasure to be part of this conference. It's a very important subject, and I'm very pleased to see that we have not only representatives of the health sector, different parts of it within the country, but also a number of visitors from abroad. So let me in particular welcome our foreign guests. I hope they find not only the conference, I'm sure they find very useful, but I hope they get an opportunity to look around the country at this time and get a sense of India also. So you're all very welcome. You know, health is such an important subject that there's a very serious danger in any public discussion on health of everybody sort of using phrases which simply lead to everyone applauding. And I mean, there's a role for that, because a public occasion which leads to an endorsement of the importance of health to those people who don't recognize its importance, a public occasion that enables the government to say that, look, we also think health is very important, which typically means we're willing to put some money in it, and we're also willing to look at policies which would move the sector forward. This is actually good and useful, and I'm not going to say too much about that because I'm going to take it for granted that is indeed the perception of the government of India. You know, it's particularly so, I think, because with the economic reforms and the liberalization and so on, the general approach for many sectors is that problems will be taken care of by well-functioning markets as long as you can afford to buy the commodity in question. And of course, one recognizes that in the case of health, many people cannot afford to buy an essential package of health services, and therefore the government must intervene. Now, first point I want to make is not as simple as that. Health is one of those areas where even if you can afford, you may not actually be buying a particularly good health package. Market failure in health exists unconnected with whether you can afford to pay. So this is the first thing, which is not the same, for example, when it comes to the automobile sector. I mean, in the case of the automobile sector, I mean, you know, if you can't afford to buy a car, well, you buy a scooter, and if you can't afford that, yes, well, then that's a problem. But you don't normally worry too much about people who can afford to buy cars because they may be making the wrong choice. And you leave that to the market, their own intelligence, information, etc. That is not necessarily true in the case of health. And I think this needs to be understood by everyone. It gives a very special role to the government. It gives a very special role to regulation. But at the same time, it doesn't mean that you take away choice. That would be an absurd outcome also. So that's why what constitutes an intelligent approach to health, anchored in the clear recognition that the government has to spend more money, but at the same time, a recognition that you've got to spend it intelligently and got to create a framework which actually makes sense. This is actually quite difficult. I think anyone who's attended a conference in health will know that some basic numbers, and the most basic number is that India spends 4% of GDP on health, of which a little over 1% is spent by the government. And I think everybody agrees that this little over 1% is not good enough. People differ on what that should be, but I'm not aware of anyone who thinks that it should be less than 50% of the total. Many people think that 4% at our level of per capita income, 4% of GDP being spent on health is not such a bad number. Maybe it will obviously go up over time. You know, I'm very struck by the fact that the numbers in the United States, that way back in 1960, the US spent a little over 4% of their GDP, the GDP at that time, on health. And that number has since increased to 18%. I mean, the US, I think, spends 18% of GDP on health, and Europe probably makes do with half of that, or even a little less than half of that. Nobody that I'm aware of believes that the Americans are buying twice as good health as the Europeans are. So it's quite clear that there's an issue that we need to address. We are very far from those kinds of problems, but as we try to evolve our health policy, we have to keep that in mind. Now that's the first point. The second point is, particularly to those of our guests from abroad, health in terms of health care is actually not a central government subject under the Constitution. I mean, health care is a state government subject. The only thing in the Constitution relating to health, which is directly curative health, which is directly the responsibility of the center, is actually medical education. So the center sets up lots of, should set up more institutes that are teaching hospitals. But the normal healthcare is really done by state governments. And of course, the center is free to help state governments. So we provide some money, but the actual management of healthcare, primary, secondary, and tertiary, is actually the responsibility of state governments. One of the big problems, this is really to the Indian side of the audience, one of the big problems here is what is the relative role of the center versus the states? NGOs who are very concerned about the need to spend on health invariably say, well, this is the amount it should be, and the central government should make up the difference. Our experience, by the way, is that as the central government provides more, the state government provides less. So I think one of the fundamental things we have to recognize is that if health is important, state governments have to do their share. I'm not saying that the central government doesn't have to do more, it has to do a lot more. But I think it has to be done in a manner where it incentivizes state governments also to do more. An obvious question that arises is it just a matter of money? In the sense that if we had the money, we'd solve the problem. The answer is no. There are two very crucial issues that need to be addressed, on which, incidentally, there are huge differences of opinion also. One of them is clearly the whole question of human resources for health. I think some references were made earlier. There's no doubt that by most of these parameters that one judges, we probably need twice as many doctors per 1,000 or 10,000 of the population as we have, and maybe 3 times as many nurses and paramedical staff. So that is a huge task, and one of the controversial issues here is how much of this is going to be made good by an expansion of public universities, and how much is going to be made good by an expansion of private medical universities. If you get into the details of this, there are huge differences of view. So this is one example of public-private partnership where when you get down to the nitty-gritty, people tend to have different views. To my mind, it's totally clear that the central government and the state governments need to do much more than they're doing. And we are, as a matter of fact, we have initiated programs that will basically allow many of the district hospitals, which meet some criteria, to be expanded into teaching hospitals. So over time, the public sector supply of trained personnel will increase. One big issue here is really, what do we do with this very large human resource in terms of traditional medicine, which does exist? And they're actually available in rural areas, whereas an allopathic doctor is not readily available in rural areas. Again, one bunch say that, this lot can be reasonably trained into some sort of licentiate degree, etc., and that should allow them to make prescriptions using antibiotics and various other allopathic sort of medicines. If you would do that, it would hugely facilitate the extension of what one otherwise calls modern medicine in rural areas. Hugely controversial. I mean, every time I meet an association of doctors, they are totally opposed to this. I'm not a doctor, so one has to go by technical expertise. On the other hand, whenever I meet NGOs, they're very insistent that this should be done. The present situation is that we've made room in the public health system for practitioners of traditional medicine to practice traditional medicine. But what we have not done is to define the kind of things which, through some little additional training, would actually enable them to practice allopathic medicine. Now, some states have done this, but it's a controversial issue. And I think as one thinks of the rolling out of modern medicine in rural areas, because, you know, we're certainly going to be producing many more doctors, but our ability to persuade these doctors to go to rural areas is actually extremely limited. So one big choice. I mean, can we integrate the available resource of traditional medicine practitioners into the public sector clinics in order to enable them also to prescribe allopathic medicine? Very big issue, very controversial. A related question that I think was touched upon is the government has to provide a lot of money, no question about that. But should the government be doing that simply in the form of expanding the public service supply, a public supply of health services through government hospitals? Or should it do that by paying for access to private sector services? We have, in the form of the Rashtriya Swasth Bima Yojana, which translated means the National Health Insurance Program, for lower income people, we have in fact created a system where the central government subsidizes 75% and the state government picks up the other 25% for inpatient treatment. And this is an insurance scheme which allows private practitioners to offer particular types of procedures on a predetermined rate, which is a cashless transaction for the person who's insured. And I forget the exact number, but probably around now, maybe 300 million people are really covered by that insurance. Now, there are issues about, you know, what is the scope of the coverage, the cap, and all that will remain. And over time, clearly, the amount of money we have to pay will have to increase, and the cap will also go up. It's a matter of affordability. But one of the big problems that we have to face here, and I find health professionals, or rather health, not necessarily clinicians, but those concerned about public health, express grave reservations about the use of reimbursement-based insurance to expand access to health services. Now, we know from the literature, international literature, that unless this is regulated very strictly, there will be a tremendous incentive to overprescribe and to undertake unnecessary procedures. I think some of the data actually show that, in the sense that the percentage of cesarean deliveries through this system has increased hugely beyond what would be normal if the prescription of the procedure was based on a strict protocol. I mean, it's quite obvious that if you're going to be reimbursed for it, I mean, everybody is encouraged to go off and have a cesarean delivery. So how do we handle that? And this can become more and more complicated as the insurance system allows you to treat more complex situations. Now, Dr. Reddy chaired a committee that we had set up on universal health. And I think they made, to my mind, a very sensible suggestion that rather than have an insurance-based health system, we ought to move to some kind of integrated provision of health based on a per capita payment. So you set up in a geographic area somebody who undertakes to look after the health of the population, and on an actuarial basis you work out what are the number of different procedures per million people covered that would probably come up, and you pay in on a per person basis something that would cover that cost. Now that creates a huge incentive on the part of whoever is managing that system to minimize costs. Now this creates another problem. The chaps may simply not want to undertake a necessary procedure because they save costs. But on the other hand, it creates a huge incentive to manage wellness in the sense of catching diseases early. And I mean, with the current technological capability, if you had an integrated service provision with a gateway function, where basically you would first go to the primary healthcare provider, and only if the primary healthcare provider felt you needed something higher up, you'd go higher up. You could set up mechanisms where standards of service, etc., would be assured. Private individuals or companies or even healthcare providers could buy into this system in whatever way is felt to be appropriate. But then you would have a system where I'm managing healthcare for 1 million people, and I know I'm going to get so much money per year, and I have a great incentive to make sure that if somebody has been diagnosed with, is hypertensive, that not only the person is treated, but he's periodically reminded that you haven't collected your blood pressure medicines, etc., etc., etc. Now, we have asked the state governments to come up with proposals for implementing universal health care in one district. I mean, we don't know what the cost of universal health care will be, and while in due course we'll certainly cover it, it's not very sensible to lay down that this is our method of universal health care and we're rolling it out. I think unlike the Chinese, who've been very sensible in this, we don't experiment enough. So as a conscious act of learning from the Chinese, sort of you cross the river by feeling the stones, I think that's the Chinese phrase, we said let every state government offer one district where they want to implement universal health care, and let them come forward with what do they think is the best way of doing it. And we haven't said, by the way, that do it through this integrated care approach. And I believe the health ministry has received many recommendations from states, though I fear, from what I know, is that all that the states have said is, in this district there are so many people, we need so many primary health centers, we need so many secondary, just give us more money. I mean, that's just a scaling up of the existing system, not, in my view, very imaginative. But I think if there are more imaginative ways of doing it, that would be very good. And clearly, the issue has been touched upon earlier, the role of public-private partnership. You know, one of the distinctive characteristics of India is that we are running a dual system. And we have a private system, and we have a public system. There is no prejudice against the private system. There is a strong commitment to expand the public system. And the interesting thing is that both of these silos suffer from quality variation. I mean, I think I can probably say that the best of the private sector health system in India is probably as good as you can expect anywhere in the world. And I think Dr. Reddy deserves a lot of approbation and applause for having made this possible. And there are others also in the private sector who are putting up first-class facilities. Equally, he shouldn't be held responsible for the quality of the worst private sector hospitals in India, because that can be really bad. And much the same thing is true of the public sector. The best Indian public sector hospitals suffer from a lot of constraints in terms of resources, but in the end are providing some very cheap and very high quality healthcare. But equally, the quality of what goes on in the public sector system lower down and across the country varies enormously. So I think we do need to see huge improvements, and we do need to see greater participation between the two. And it seems to me that if we are to move forward in universal health care, then one of the things we're looking for in offering to support a district-specific program is to have state governments come up with variety. There's no reason on earth why we should think that there's only one way of doing it. We have, with the imminent splitting of Andhra Pradesh, we'll have 29 states, and absolutely no reason why we shouldn't have 29 experimental efforts with different states coming up with different ways of trying to implement universal health care. I do want to mention, by the way, that in a lot of the discussion on health, you tend to get two different messages. And one of the good things about having a free and critical press is that it serves a very important role of constantly reminding the government what's not happening. So we're very aware of the deficiencies. But I do feel that things need to be put in perspective. And when one puts them in perspective, it cannot really be said that we're not improving in the area of healthcare. Though very often critics that I talk to often give that. I mean, we have to remember that the expectation of life at independence was 37 years and it's now 67. So something must have been happening right during this period. We have just a month ago been declared polio-free. Now, that cuts both ways. I mean, we were one of the last of 3 countries or so that weren't polio-free. So it's not as if we are leaders in the field. But the fact that the country is now polio-free is certainly a major, major achievement. And I would say that one of the things that comes out, we need to focus on in evolving a health strategy is what's the most cost-effective way of getting results. And there's no question that immunization, vaccination, those are the cheapest ways of getting good results. And frankly, I think while the polio success is a great success, I think in many of the other areas, basic immunization of children, we still have quite a long way to go. There are large chunks of the country where, you know, the success of immunization is less than 70%. There's absolutely no reason why it should not go up to 95%, if not higher. And many of those are low-cost interventions which would actually make a huge difference to the health of the Indian population. But equally, as prosperity increases and longevity increases, we are going to become vulnerable to the whole burden of non-communicable diseases. You know, somebody said that we are the diabetes capital of the world. I think since we're not the world's largest population yet, there's an implicit criticism in that, but very soon we are going to be the world's largest population. So please be ready that in another 15 years, we will be the capital of every major disease if you judge it not in terms of incidence, but in absolute numbers. I mean, simply because of the size of the population. So as a matter of fact, some people would even say that it's going to be a measure of the rising prosperity that the burden of disease is going to shift. So we're going to have less and less of some of the communicable diseases, but inevitably have more and more of the non-communicable diseases. I believe somebody wrote a piece in Lancet or somewhere who asserted that rural prosperity in India is leading to a big increase in diabetes in rural India, which is true. He wasn't actually saying, let's not have rural prosperity. He was just saying, look, now that you have rural prosperity, and if you don't alter your lifestyle and you don't take appropriate precautionary measures, you run all these risks. I think we need to put all of this together somehow. I do feel that the next 10 years should be seen as years where India has a great potential to have actually fixed many of these problems in the sense of delivering a reasonably good quality health, curative and preventive and curative healthcare services of the kind that visibly will lead to improvements in health outcomes and health indicators. So conferences like this, bringing together both the public sector, the private sector, the NGOs, presumably also the pharmaceutical sector. I didn't talk about the pharmaceutical sector, but if you really want to have differences of opinion and controversies, there's a huge range where there are lots of differences that need to be resolved. So quite frankly, I've seen the papers. I'm going to take them away and read them. But it'd be very good if out of this conference, you focus a lot on what are the areas of agreement, but what are the continuing areas of controversy? Because I think those are not going to disappear. And it's only if people recognize that these controversies are natural in this area, exist everywhere in the world, that we will get around to a sensible approach to how do we tackle them in our particular circumstances. So with those words, thank you very much for inviting me to the conference.